My talk is on the clinical consequences of bare metal stent and stent graft failure in the treatment of femoral popliteal occlusive disease. So we all know that PAD is a widely prevalent disease and affects up to 20% of the population over the age of 70. In America, over the last decade, the frequency of percutaneous revascularization techniques has increased threefold. This is because we have a high technical success rate, patients want it, there's less patient discomfort, quicker recovery, and very low peri-procedural morbidity. But despite these advantages, there is a frequent need for reintervention. And as of now, I think we have an incomplete understanding of the risk factors for reintervention, as well as the clinical consequences of failure of this technique. Both bare metal stents and stent grafts have been shown to be effective revascularization techniques in the superficial femoral artery. However, nitinol stents have only been randomized against balloon angioplasty in trials and stent grafts against prosthetic bypass grafts. There are currently prospective studies comparing bare metal stents to stent grafts, the Vibrant and the Viastar trials, but to date these trials have not been published. So we wanted to look to our own data to see if we could answer a few of these research questions. And we specifically wanted to compare the clinical outcomes between those treated with bare metal stents versus stent grafts for femoral popliteal occlusive disease. And we wanted to evaluate the frequency and magnitude of the adverse clinical events, as well as the risk factors for adverse clinical events and for reintervention. And we wanted to look how these differed between the two groups that were treated. So this was a retrospective study that we did at our own institution between October of 2007 and December of 2011. We included patients who were undergoing their first treatment for infrainguinal occlusive disease and only included patients who were treated with either a bare metal stent or a stent graft. And they had to have had at least one follow-up outpatient visit after discharge. We excluded any patients who had had a previous infrainguinal intervention, but we allowed those who had had a previous inflow procedure or a below ankle amputation. All of the stent grafts that were implanted were the Gore heparin-bonded Viabond stent grafts. We had a variety of bare metal stents, however, that were implanted in these patients. We collected a number of SETI variables that you can see on this slide. And we chose to look at 4 clinical endpoints, 2 of which were composite endpoints. The first was RAS, which is any reintervention, major amputation, or stenosis based on ultrasound or angiography. The second composite endpoint was a major adverse limb event, which included a bypass procedure, thrombolysis or thrombectomy, or major amputation. And then we also looked at the outcome of acute limb ischemia according to the Rutherford classification, as well as the subgroup of claudicants who progressed to either critical limb ischemia or acute limb ischemia. This is the demographics of our cohort. 71 limbs underwent treatment with a bare metal stent, 63 underwent placement of a stent graft. And in general, the two groups were fairly similar with the exception of age. Those treated with a bare metal stent were older than those in the stent graft group. And there was also a higher proportion of those with end-stage renal disease in the bare metal stent group. The patients with, so in general, the patients treated with a bare metal stent were equally divided between claudicants and critical limb ischemia, whereas those treated with a stent graft were more likely to be claudicants. And as you can see here, there was more patients with gangrene treated in the bare metal stent group, Rutherford class 6. The patients treated with a stent graft were more likely to have task D lesions compared to those with the bare metal stent, and more likely to have a chronic total occlusion. However, those treated with a bare metal stent were more disadvantaged in terms of their runoff score. We use the modified SVS runoff score, where 0 is the best and 3 is the worst. And you can see here the bare metal stent treated group had a worse runoff compared to the stent graft group. The minimum device size that was implanted was similar in both groups. However, in the bare metal stent group, there were 8 limbs that had a stent implanted into the popliteal artery. And in the stent graft group, there were none. The stent graft group had a larger proportion of patients who had greater than or equal to 3 devices implanted. The majority of patients underwent treatment with dual antiplatelet medications on discharge. So these are the results for freedom from RAS, so reintervention, amputation, or stenosis. And as you can see, at 1 year, freedom from RAS favored the stent graft group compared to the bare metal stent group, and this finding was statistically significant. We then wanted to figure out what were the predictors for RAS in this group. And on univariate comparison, we found that male gender, a larger diameter stent or stent graft, or using a stent graft over a bare metal stent was protective from reintervention at 1 year, whereas end-stage renal disease was associated with an increased risk of reintervention at 1 year. In the multivariable model, this basically held up. Again, using a stent graft over a bare metal stent was protective against RAS at 1 year, as was a larger diameter device, whereas having a CTO or end-stage renal disease was associated with an increased risk of RAS at 1 year. What about for major adverse limb events? We did this analysis by the final treatment received because 13 patients with a bare metal stent actually crossed over to the stent graft group. And as you can see from this survival analysis, there was no significant difference in terms of major adverse limb events when you compare the two groups. However, there was a significantly larger proportion of patients in the stent graft group that required thrombolysis when the stent graft failed compared to the bare metal stent group. With regards to the amputation, all 4 of these patients in the bare metal stent group presented with Rutherford class 6 classification, so they had gangrene, and all of these underwent a major amputation within the first 4 months after treatment. You could have made an argument that perhaps they should have undergone a major amputation prior to an attempt at limb salvage. In terms of the multivariable analysis of predictors for major adverse limb events, again, end-stage renal disease was a strong predictor. However, if you look at the subgroup of those requiring thrombolysis, you can see that a stent graft or chronic total occlusion was associated with an increased risk of a major adverse limb event. For the outcome of acute limb ischemia, no patients who were treated with the bare metal stent subsequently developed acute limb ischemia when that stent failed. However, 9 patients in the stent graft group did develop acute limb ischemia when that stent graft went down. It's also important to note that actually 5 of these 9 patients were initially treated for claudication as their indication for the procedure. And then looking at the predictors of acute limb ischemia, again, use of a stent graft or chronic total occlusion was associated with a higher risk of acute limb ischemia, and this just demonstrates each of these 9 patients and their outcomes. We then wanted to look at the claudicant subgroup, really to determine what subset of these patients progressed to critical limb ischemia or acute limb ischemia when the stent or the stent graft failed. And as you can see in the claudicant subgroup, the findings are pretty similar to the entire cohort. However, there was a greater proportion of claudicants in the stent graft treated group who ended up progressing to critical limb ischemia or acute limb ischemia when that stent graft failed. This did not reach statistical significance. So in summary, the frequency of any reintervention was lower in the stent graft group at 1 year, and I think that our findings are quite similar to other published reports. However, when those reinterventions were required, they were actually more severe in the stent graft treated groups, with higher rates of thrombolysis and a higher rate of acute limb ischemia on failure. And oftentimes, the development of acute limb ischemia was unpredictable because in many of these cases, they were preceded by actually a normal ultrasound. Failure of either device in the claudicants does not necessarily revert the limb back to claudication. 17% of the stent graft failures progress to either critical limb ischemia or acute limb ischemia. There are a number of limitations to our study. Obviously, this is a retrospective analysis of our own data, so there could be a significant source of selection bias. There was also very important differences between the two cohorts. There were more task D lesions and claudicants in the stent graft group, whereas there were more critical limb ischemia patients with disadvantaged runoff in the bare metal stent group. We also had a fairly poor compliance with our ultrasound surveillance, but we do think that our experience does reflect a real-world scenario in these treated patients. Thank you.
Dr. Luiz Carlos, por favor, seja breve. Nosso presidente está na primeira fila. Estamos com o tempo estourado. Manda quem pode e obedece quem tem juízo. Rápido.
Só para ser mais conclusivo, o trabalho da senhora mostra que realmente as endopróteses, elas por ocluírem as colaterais, acaba sendo uma endoprótese teoricamente mais perigosa quando a gente tem as oclusões. E o stent descoberto nessa situação apresenta vantagens. A taxa de reintervenção, a senhora acha que justifica a escolha da endoprótese em detrimento do stent não revestido? Há uma diferença? Há como fazer uma escolha baseada nos seus trabalhos, nos seus resultados?
Again, I think it's difficult to make any kind of formal conclusions based on this study, but I would suggest that people be a little hesitant maybe about treating a claudicant with a complete total occlusion in a TAS D lesion. That's and covering a significant number of collaterals. I think in that subgroup we found that that person, when that stent graft goes down, is at risk for not reverting back to claudication, but instead progressing to either critical or acute limb ischemia. So claudicant, TAS D lesion, complete total occlusion, that might be the subgroup where you think a little harder about just putting in a stent graft.
Muito bem. Então, nós estamos realmente pressionados com o tempo, aí o presidente tem razão de estar adiante. A culpa não é nossa, temos a mesa atrasada, mas o programa tem que continuar. Eu vou pedir para o Dr. Júlio fazer as palavras finais dele, antes de a gente passar a palavra para o nosso presidente.
Eu gostaria de fazer algumas perguntas, mas infelizmente não as farei pelo jantar da hora. Gostaria de agradecer a comissão organizadora pelo convite e dar os parabéns a todos os palestrantes.
Ok, para não deixar de dizer nada.